Hey everyone, and welcome to week 4 of Bio 6601, Environmental and Biological Ethics. I'm Dr. Kaelyn Fogelman, and this week we're going to dive into a topic that is absolutely central to ethical research and patient care. That topic is informed consent, and it's going to come along with its companion topic, health literacy. So before we jump into our formal lecture, I want to ground our discussion in something more reflective. So we've spent some time over the past week exploring one of the darkest chapters of biomedical history in the United States, which was the Tuskegee syphilis experiments. So I want to start today by inviting you to pause and really think about the ethical questions that emerged from that case. We're going to return to these throughout the week as we build out a more detailed understanding of informed consent and what that truly means legally, ethically, and practically. Before we get too deep into the technical aspects of informed consent, I want to take a moment and reflect while we return to our earlier thoughts on the Tuskegee syphilis experiments. And there have been other unethical research studies throughout history, as you all have talked about in your discussions, as well as what we'll continue to explore this week. So many have expressed disbelief and outrage, asking how in the world could something like this happen? Like the Tuskegee experiments, like some of those other medical research experiments that you guys have explored in your discussions. So let's go a little bit further, asking ourselves, could similar things to these happen again? Maybe not in the exact same way as the Tuskegee experiments, for example, but are there modern parallels? Could comparable ethical oversights occur in today's research environment? So think about the ways that certain groups have been historically exploited or excluded in research. And not just historically, but today. So women, for example, were often left out of clinical trials until the 1990s. Other individuals, like prisoners or racial minorities, have been included in research trials disproportionately and not always ethically. So here's some big questions that I want you to just kind of think about as we get into this lecture. One of which, to what extent should we consider human differences in research? Should we treat everyone the same and avoid singling out groups? Or should we recognize that race, sex, and age and other factors may be relevant in a study design? So we talked about how the Tuskegee syphilis experiments were grounded in racist misinformation, or this idea that Black individuals were affected differently by disease pathology from white individuals. But what about when there are actual differences in groups, such as making sure that we do research on women versus men in clinical trials? So these aren't just scientific questions that I want you to think about, these are deeply ethical questions. We're going to continue to return to these again and again this week. So let's start with one of our thorniest questions in bioethics. Is it ever ethical to harm a few for the benefit of many? So to bring this closer to home, consider the case of Bertus Hardeman. I put a little video introducing you to this case in your week 4 module. But this story is featured in the documentary Hole in the Head. He was one of several African American children subjected to radiation experiments in the 1950s. Bertus Hardeman was the youngest, he was 5 years old, and these experiments were done under the false promise of treating ringworm. So as an adult, Hardeman lived with a literal hole in his skull, which was a result of those experiments, and yet those same radiation studies contributed to advances in our understanding of radiation exposure. So we have to ask, was the greater good of our current knowledge of radiation, the harms of radiation today, was that worth the consequences as those children suffered by being exposed to that radiation? So as we explore informed consent, we're going to come back to our ethical pillars. So we have autonomy, the right to make informed decisions about one's own care, beneficence, or acting in the patient's best interest, non-maleficence, doing no harm, and justice, fairness in how we distribute risks and benefits. So these 4 pillars, these aren't just philosophical terms, they're the heart of ethical clinical research, as we've been discussing. So in this question of could this happen again, could something like the Tuskegee syphilis experiments or the Virtus Hardeman case happen today? Honestly, yes, in some forms, especially given the wrong conditions, or you could say the right conditions or right circumstances. So think about how research is conducted during emergencies. COVID-19 crisis, for example. If there's a pressing public health crisis, governments and institutions could bypass traditional research safeguards in the name of urgency or national security. So I'm not implying that the research that went into producing the COVID-19 vaccine, for example, was unethical or there was any wrongdoing there, but I'm using this as an example of if we are in a time-sensitive situation where we have to weigh the good of the few versus, or the good of the many versus harm to a few, what is the ethical foundation in that? So we've also seen unethical research involving detainees and prisoners that have occurred. This includes US-led studies in Guatemala in the 1940s where individuals were deliberately infected with syphilis. In Utah, chemical weapons were tested on individuals without full disclosure that the chemical weapons were being used, so individuals being housed in those areas as part of the military were exposed to the weapons that were being tested. And then in Holmesburg Prison in Philadelphia, Pennsylvania, inmates were subjected to dermatological experiments for years. So often, these groups did not know to ask about IRB approval or the Institutional Review Board, which is, we talked about, one of the things that arose following the Tuskegee syphilis experiments. So individuals didn't know to ask for that because they didn't know that experiments were being conducted on them, or they didn't have the agency to say no. So if we think about a situation like detainees or prisoners, they're not really in a position to, even if they have knowledge of what's being done to them, deny that from occurring. So it really leaves us with these questions. Who is vulnerable, and how do we protect those individuals that are vulnerable, not just legally, but ethically when we design and conduct research? So these are very pressing things to think about today as we see increased incidents of detainees and prisoners where we don't know if those individuals have agency over themselves or not. So lots of things to continue to think about in modern day. Because we can continue to turn to some more subtle ethical lapses. Experiments done on detainees, that's very obviously a very serious ethical violation, but let's think about some things that are a little less egregious than that, than the Tuskegee experiment, for example, or looking at the effects of chemical weapons on individuals living in a certain area. So these ones did not involve physical harm per se, but they did so raise serious ethical concerns. So in 1990s, tribal members of a Native American tribe in Arizona gave blood samples to researchers at Arizona State, thinking that these blood samples were going towards research that was going to help fight high rates of diabetes in their community. Later, they learned that those samples were instead used to study mental illness, inbreeding, and migration patterns. Again, some questions that may be rooted in racism as well. And these topics also violated their cultural beliefs and were never disclosed that that was the true nature of the research being conducted. There was also a Facebook emotional contagion study that was conducted in 2008, which manipulated users' feeds to study mood effects. That did not involve informed consent. So while these people were not physically harmed, it did violate trust and autonomy. Also, even respected institutions such as medical schools or higher education institutions have crossed lines. In 2016, an ophthalmologist at University of California, San Diego violated IRB rules by performing eye injections without proper consent. Another study at NYU tested marijuana analogs on PTSD patients, but failed to properly educate or follow up with those participants. So again, informed consent is more than just a signed form. It's about transparency, honesty, and respect. Giving that to the patient that's involved so that they can, or the participant that's involved, so that they can decide whether they want to be involved in this or not. So if you're interested in learning more about any of these examples that I've given on the previous slide or this slide here, I've included links to some resources, whether it's the original study or a study following up discussing the ethical violations of that. So each of these citations here can be referenced to a reference slide at the end of this lecture, so you can dig a little bit deeper into these instances. So this brings us to another key question. Can clinical care and research happen at the same time? Or is clinical care and research, are those fundamentally different activities? It's a very tricky line. On one hand, when a doctor gives a patient a new drug, there is an element of experimentation. Every person reacts differently, as we discussed adverse drug reactions in the previous lecture. But in a way, medicine is always part science, always part art. Clinical research has a very different goal than medicine: to produce generalizable knowledge, not to help one specific person. And that distinction really matters. When those lines blur, patients may think that they're getting personalized care when really they are part of a study. So this leads to what's called therapeutic misconception, as we're going to continue to talk about in this lecture. But if participants don't understand the true nature of the study, or that they're involved in a study, and they believe that they're getting tailored care, they can't give valid, informed consent. Ethically, research and therapy require different approaches. That's why it's so important to clearly define the setting, the goals, and the risks up front, and in language that participants can actually understand. So let's break down exactly what a clinical trial is. At its core, a clinical trial is a scientific study conducted in a medical setting, usually involving people, to test the safety and effectiveness of new treatments, therapies, or procedures. It's not just about new drugs. Trials can test medications, surgical techniques, medical devices, even behavioral interventions. Or they can look at ways to improve quality of life. So now it's very important for us to understand there is uncertainty. That's why trials are so highly regulated, or at least they should be highly regulated. The ethics that we apply here help to ensure that people aren't treated like guinea pigs, but as informed, autonomous participants in the process. There are several different kinds of clinical trials, each with their own purpose. Treatment trials test new ways to treat a disease, often comparing them to existing therapies. Prevention trials look at strategies to prevent illness, especially in at-risk populations. Early detection or screening trials help find diseases earlier at more treatable stages. And diagnostic trials evaluate better methods for identifying conditions accurately and quickly. Each of these trials involves participants who are ideally fully informed about what they're taking part in, why it matters, and what the risks are. We'll come back to that idea of informed consent in just a minute. So we'll talk about now who is involved in these clinical trials. These are team efforts, and they involve a wide variety of professionals. So you have principal investigators or physician investigators. These are the doctors, and they lead the trial. Your research nurses and your clinical coordinators are those that manage the day-to-day logistics. You also have pharmacists, lab technicians, or social workers, and those individuals are involved in more of a support aspect in the trial. You'll have data managers and biostatisticians who handle the data analysis, because at the end of the day, this is research. We are doing something to collect data on the effect of what we were doing, and we need individuals who will analyze and interpret that data for us. But most importantly, we have participants in a trial. Those are the human subject volunteers. They could be healthy, or they could be patients with a specific condition that's being evaluated. So these individuals, the patients, are the heart of the study. Without them, the research does not happen. This is why it is so important to respect their rights. This is essential in clinical research. And this is why informed consent is both a moral and a legal requirement. Before a trial ever begins, researchers have to submit a clinical research proposal. This proposal will lay out the objective of the study, so what are the physician or principal investigators trying to discover? It will lay out the background and rationale, so this is the justification that they make for why is this study necessary, why can't these data be collected in other means that maybe don't involve human participants. It will discuss how participants will be selected, as well as the treatment plan and the study procedures. There will be criteria for evaluating results, so what counts as success? What outcomes are we looking for? And it will also reveal the statistical method that's going to be used to analyze outcomes. So we can't just have raw data and say, yes, this had an effect, or yes, this is the way we should do things going forward. There has to be statistics involved with that. The proposal will then go to an institutional review board, or IRB, for approval. So the IRB jobs, which we'll discuss in a little bit more depth in this lecture, their job is to review the ethics and protect participants. So we'll take a deeper dive now into what the institutional review board does. The Institutional Review Board, or the IRB for short, is a watchdog for ethics in human research. IRBs are made up of a diverse group of people. These are doctors, nurses, statisticians, community members, experts in the field. These individuals are all tasked with asking, is this research ethical? Are the risks reasonable? Are participants fully protected? All research involving humans and primates must be reviewed and approved by an IRB before it can begin. The IRB looks at things like risk versus benefit. It looks at participant selection. Is the participant selection fair? Is it targeting or excluding certain groups of people? It looks at informed consent procedures, and it evaluates if there are any potential conflicts of interest, which we'll also discuss later in this lecture. So without IRB approval, the research cannot legally proceed, and any ongoing studies are monitored throughout their duration to make sure nothing goes off the rails. What was approved prior to your study by the IRB must continue to be upheld throughout the duration of your experiment as well. Now let's focus on informed consent. This is the foundation for ethical human research. Informed consent is not just a form that somebody signs to say, yes, I want to be involved in this. Informed consent is a process. It starts before any research begins, and it continues throughout the entire study. Participants must be given clear, understandable information about the purpose of the study, any risks or potential benefits, alternative treatments, if those are applicable, how their privacy will be protected, who to contact for questions, and critically, that participation is voluntary. The standard here is what a reasonable person would want to know, and the information must be provided in language and format that all participants can understand, and that information has to be provided and consent given free from coercion or pressure. As the U.S. Department of Health and Human Services states, informed consent is about autonomy and respect for persons. This is not just about checking a box. So this information, how informed consent will be given and maintained, must be part of the IRB submission. So this is something that the researchers have to think of in advance, and they have to put into their IRB proposal to receive permission to conduct that study. So this is a critical and integral part of any research being conducted with human or primate subjects. This is not just an afterthought that you make sure you're maintaining. It's something that's integrated into your procedures and plans from the front end. Now let's go a little deeper into how informed consent actually works in practice. So informed consent is not just a one and done moment, as we mentioned. This is a continuous communication process between the researchers and the participants. This begins before the study even starts, and it should continue throughout the entire study, especially if anything changes along the way, which is part of what the IRB is responsible for ensuring. Researchers are responsible for providing all relevant information, the risks, the benefits, the alternatives. They're responsible for doing so in language and format that's understandable. They're responsible for ensuring that the participant truly comprehends what they're agreeing to. And once that understanding is reached, the consent is documented. This is usually in writing with a signed and dated form. That form then becomes a legal document, and a copy must be given to the participant. Some situations do require extra steps. So if consent is given orally, a witness may be required. Children cannot legally provide consent. A parent or guardian must sign on their behalf. And in some cases, such as research involving pregnant women, the father's consent also may be needed, depending on the study and the IRB regulations. These procedural steps are all part of the broader ethical obligation to respect and protect the autonomy of every participant in the study that may be affected. There is a checklist by the U.S. Department of Health and Human Services that outlines everything that needs to be detailed within the informed consent process, and this can be found on the HHS website, which is linked in your resources. So let's discuss who can't legally or ethically give informed consent. We mentioned children, but there are several key groups that include individuals with mental illness or cognitive impairment, individuals that are intoxicated by drugs or alcohol, individuals with altered mental status like confusion or brain injury, and anyone under the age of 19. So these individuals either lack decision-making capacity or they aren't considered legally competent to consent. So in these cases, consent must be obtained from a legally authorized representative, such as a parent, guardian, or a healthcare proxy. And for some vulnerable groups, like children or pregnant women, additional protections may be required. So for example, as I mentioned with pregnant women, for certain studies, the consent of the father may also need to be obtained, just depending on the nature of the study. The key point here is that vulnerability requires protection, not exclusion, but thoughtful ethical inclusion under stricter oversight. So now let's talk about conflicts of interest, or COIs. This is a crucial and sometimes overlooked piece of the research ethics puzzle. A conflict of interest occurs when a researcher's personal or financial interests may compromise their professional judgment or even just appear to compromise their judgment. Conflicts of interest can show up in all phases of the research. So whether this is choosing a protocol, collecting or interpreting data, reporting results, or even deciding which participants are selected in a study. Most people think of financial conflicts like being paid by a drug company, but there are non-financial conflicts of interest such as academic pressure, personal bias, or competition, and those can be just as dangerous. Even the appearance of a conflict of interest can damage trust. That's why IRBs require full disclosure and why researchers must proactively guard against bias, not only for the integrity of the study, but for the protection of their subjects. And conflict of interest reports are not just something that needs to go into research involving human studies as well. I, as somebody who does animal research, I often have to submit conflict of interest statements as well for much of my research, especially if it's federal funding. So this brings us to one of the most fascinating ethical debates in biomedicine. Can clinical research and clinical therapy coexist? So there's two main positions. The first being the similarity position, which says they can and should follow the same ethical rules because both involve treating patients and making decisions that affect people's lives. The difference position argues that research and therapy are fundamentally different. Therapy is about helping this individual patient, and research is about generating knowledge for future patients. This distinction really matters for informed consent. So if a patient believes they're receiving personalized care when they're actually part of an experimental protocol, that is a huge ethical problem. And this brings us to one of the most common and serious issues in research ethics, which is therapeutic misconception. In the world of therapeutic medicine, the goal is clear: help the individual patient. The ethical principles guiding this are therapeutic beneficence, doing good, and therapeutic non-maleficence, which is avoiding harm. Any new knowledge that comes from treating the patient is secondary. It is not the goal. Think of this as traditional one-on-one care. A doctor prescribes a treatment because it's in the patient's best interest, not because they want to test a theory or publish a paper. This model is built on a deeply personalized, compassionate framework, and it is very different from research, as we'll see next. If we contrast that with the world of clinical research, here the primary goal is to gain generalized knowledge, which is information that can help future patients, not necessarily the individual in the study. Ethically, research relies on autonomy, non-maleficence, and a utilitarian balance. This balances risk and benefit and asks, does the knowledge gained justify the risks to participants? This is where therapeutic misconception becomes dangerous. If a participant thinks they're receiving individualized care, when they're really just one subject among many, they may not fully grasp what they're agreeing to. And that means that true informed consent has not been given. This is why the difference between research and therapy must clearly be explained, not just in the paperwork, but in plain human conversation between the researcher and the participant. So now that we've explored the distinction between clinical research and clinical therapy, let's talk about why this distinction is so critical, especially when it comes to informed consent. If a patient believes that they're receiving personalized therapeutic care, when in reality they're being treated according to a research protocol, they cannot truly give informed consent. Why? Because their understanding of the situation is flawed. Consent is only valid when it is based on accurate and comprehensive information. This is exactly what's meant by therapeutic misconception, as we'll go on to discuss, and it is a huge threat to ethical research. When researchers blur the line between therapy and research, as in the similarity position, they unintentionally, or sometimes intentionally, mislead participants. This can erode trust, and more importantly, it undermines the entire informed consent process. This is why clear communication, transparency about intent, and ethically sound study design are essential, especially when participants may be vulnerable or unfamiliar with how research really works. So what is therapeutic misconception? It's when a research participant confuses clinical research with clinical therapy, believing that the study is designed to directly benefit them as a patient. Even when the consent form says otherwise, people often assume that if my doctor recommends this, it must be good for me. This misunderstanding can be subtle but dangerous. So a classic study by Applebaum et al. In 1987 found that 40 to 80% of research subjects misunderstood basic aspects of trial design. Now, this was from 1887. We like to think that things are better today, but that was even after individuals had gone through the consent process. So if participants don't understand what they're signing up for, they cannot truly give consent. The takeaway here is that clarity, transparency, and empathy are essential. Researchers have a duty to communicate not just the facts, but the context, what the study is, what it isn't, and how it is different from everyday care. So let's wrap up by looking at some of the interpersonal and emotional dimensions of ethics in research and medicine, the ones that often go unspoken but are just as important. So at the core of any ethical doctor-patient or researcher-subject relationship is communication. I don't just mean paperwork here and forms that are being signed. I mean honest human interaction. So this includes verbal communication, how things are explained, nonverbal communication, tone, eye contact, presence, and most importantly, the ability to listen and ensure comprehension from the patient. Empathy also plays a huge role here. Participants, especially those in clinical trials, need to know that they're more than just a data point. They need to be seen, they need to be heard, and they need to be respected. And they not just that they need to be, they need to feel that they are as well. And what about palliative care or quality of life concerns? This raises hard questions about how research priorities intersect with personal values. A treatment might be statistically effective, but if it compromises someone's quality of life, is it truly ethical? This is where the ethics of care come into play, so emphasizing relationships, compassion, and the lived experiences of patients. It's not always about what we can do, but what we should do for each individual. So to bring it all together, a solid understanding of research ethics requires us to clearly distinguish between research and therapy, and to actively work against therapeutic misconception. We've seen how real-world cases like the Tuskegee syphilis experiments to modern-day IRB violations, how these real-world incidents continue to challenge our systems of oversight. We're going to look at another example for this week's reflection with the Henrietta Lacks case. We've seen how respect for autonomy, clarity in communication, and a deep sense of empathy are essential to preserving ethical integrity. So as we move forward this week, keep asking yourself, what does true informed consent look like? Who is vulnerable and how do we protect them? And how do we, as future science professionals, whether in the medical field or natural resource management or environmental science, how do we ensure our work is not only scientifically valid, but ethically sound? So now that we've wrapped up, let's talk about our logistics for the next week. You have a discussion board. This is going to be a structured team debate where you are on a team working to make a recommendation to the US government for or against whole genome sequencing. So I've assigned you all positions, whether you're on the for team or the against team, and your posts this week are going to be making your arguments for this advisory board. So you'll have your initial post due by Wednesday. Your responses will be due as usual by Sunday. This is also going to be an interactive discussion board. So I am going to make counter arguments against each of your for positions or your against positions. So your replies will need to be at least one to me and at least one to your a peer on the opposite team. So your movie and reflection for this week is going to be to watch The Immortal Life of Henrietta Lacks, which can be found on our Troy Library Films on Demand, as we did with our previous week's movies, Miss Evers' Boys, and then you're going to complete a reflection on that. You also have your plagiarism assignment where your peer reviews were due this week. So I will also be giving my feedback, and you have the option to do your revisions, which can be submitted up until this Wednesday, April 16th on the original assignment. So as always, if you have any questions, concerns, or you just want to check in, feel free to message me on Canvas. I'll get back to you within 24 to 48 hours. Thank you and have a great week.